Human Services Finance and Policy Committee hearing for today, Wednesday, February 24th. For the record, members, we do have a quorum. I'm going to turn the gavel over to Senator Draheim, and I don't mean to be a bill hog, but we're trying to get some things moved with some exigency and to facilitate making other committee deadlines. And with that, Senator Draheim, if you would begin chairing.
Thank you, Senator Benson, and I do have a stopwatch today, so I'm going to keep you on track of your time schedule. So today, I think the first bill up, members, is Senate File 953, Senator Benson's bill with Ramsey County Hospital Moratorium exception. Senator Benson, to your bill.
Thank you, Mr. Chair. I move Senate File 953 to be before us. Members, you remember a few years ago, Regions Hospital came to us with a bed request. We are going to be making an exception to the hospital moratorium if we pass this language through both bodies, and it is signed into law by the governor. The past year has been a historic challenge in our healthcare system, and we have seen changes accelerate that we never anticipated moving this quickly. Most hospitals in our healthcare systems have the flexibility to increase or reduce the number of staffed beds that they have. Regions Hospital has a constraint. They don't have any more licensed beds available to them. They have a statutory obligation to meet, to be the Ramsey County Safety Net Hospital. And so they come to us with the request, the constraint of not being able to operate their hospital according to the needs that they see in their community, but also the responsibility to be the safety net hospital. Additionally, they are a level 1 trauma center, and there are special requirements that come with that. And so having constraints, responsibilities, and a high standard puts them in a box. And we are going to debate whether or not we're going to help them get out of that box and be able to operate their hospital as they deem necessary. And with that, I'd like to invite Mr. Chair, at your discretion, Megan Remark, who's the president and CEO of Regions Hospital, to explain why Regions needs this exception.
Thank you, Senator Benson. Ms. Remark, please state your name for the record and begin your testimony. I think you're muted yet. The darn mute.
Thank you, Mr. Chair. My name is Megan Remark, and I am president of Regions Hospital. So I want to thank Mr. Chair and members of the committee today for hearing our testimony. Before I provide you with some background on the need for this proposal, I'd first like to thank Chair Benson and other bill authors for their support of this bill. I also want to just take a moment to express my gratitude to the legislature for your support that you provided to all of our hospitals and healthcare providers throughout this pandemic. Thank you very much. It has meant so much to our caregivers. Senate File 953 would grant Regions Hospital an additional 45 inpatient bed licenses. The need for the beds authorized in this bill can best be shown through Regions Hospital's current capacity levels. I'll provide you with some data on that, but I want to first provide some background to help you understand the unique position Regions is in that drives our request. As Senator Benson stated, Regions Hospital is the only level 1 adult and pediatric trauma and burn center in the East Metro, and we care for many patients that cannot be treated anywhere else. In 2017, our occupancy levels were higher than optimal for level 1 trauma centers. So in order to add beds to serve our patients, we submitted a request through the state's public interest review process to be granted an exception to the state's hospital bed moratorium. The hospital construction moratorium froze in time the number of inpatient bed licenses hospitals had when that bill was passed in 1984. In the case of Regions, we are in the unique position amongst large hospitals in Minnesota in that we use nearly all of our bed license capacity for patient care. Most other large hospitals have excess bed licenses beyond the number of beds that they actually staff, giving them the flexibility to expand if needed to meet community need without having to go through any legislative process to do so. We were grateful that in 2008, the legislature granted us 55 new bed licenses in order to meet community need. Of those 55 beds, 15 were designated for inpatient mental health beds. Our plan at that time was to add new mental health beds in 2025, but given the sustained high demand for inpatient mental health services, we have accelerated those plans fairly significantly, and we are now on track to add these additional mental health beds this year in 2021. Regions' current mental health building that we operate has currently 100 inpatient beds now and has space for 20 additional inpatient beds once we complete the build out of our last vacant floor there. Our plan is to use the 15 mental health beds granted in 2018, plus 5 of the 45 that we're seeking this session, for a total of 20 new inpatient mental health beds this year in the East Metro. Continuing to make Regions Hospital the largest inpatient mental health services provider in the East Metro with a total of 120 mental health beds. In 2019, we operated at an average occupancy level of 87% for inpatient medicine and surgical beds, and actually 94%, so close to full every day, for mental health beds. The national average for hospitals is currently approximately 66%. We continue to see an increased demand for Regions' inpatient medical and surgical beds as well. By the end of this year, we anticipate using all of the 55 new bed licenses that we received in 2018. And by year end 2021, we will be using all of our 509 bed licenses. Given the fact that we'll be out of bed licenses by year end, and that Regions remains at higher capacity than is considered best practice for a level 1 trauma center, we are asking this session for 45 additional beds to give us the flexibility to meet future patient demands. To share with you just a bit of an example of what happens when hospitals do not have capacity, I wanted to let you know that in 2019, due to capacity constraints in our Regions Hospital Emergency Department, we had to go on divert 161 times, meaning patients needing care had to be diverted to other hospitals in the Metro and sometimes beyond the Metro. Collectively, East Metro emergency departments had to go on divert status 555 times due to capacity limitations during this time frame. In many cases, patients are coming to the hospital with life-threatening conditions where minutes matter, and being diverted to a hospital that is further away can have serious negative consequences. I want to note that these capacity statistics, it's the important point that we as healthcare system need to do all we can to ensure patients receive the right level of care at the right time and the right place. Regions is a part of Health Partners, and we've worked towards the goal of seeing more and more patients in an outpatient setting, and have done a significant amount to reduce the demand for inpatient care. We have successfully reduced emergency department utilization through the use of primary care, urgent care, our community paramedic program, the use of online clinics, and we've also partnered with community organizations like Catholic Charities on respite bed care for those patients who can be safely discharged but need additional assistance outside the hospital. With the work to reduce unnecessary hospitalizations, the patients that we do see are sicker. They require more specialized care and intensive care, and they are often in the hospital a longer period of time, which takes additional bed capacity. In conclusion, I just want to mention that adding inpatient bed capacity is a significant investment of hospital resources that we do not undertake lightly. Regions needs these additional 45 beds to be prepared to meet the needs of our growing and aging community. Facility planning and financing timelines for hospitals are long, and our request for your support during this legislative session is key. We are not aware of any opposition to this bill, and we have the support of Ramsey County, AFSCME, and SEIU Healthcare, both of which represent employees at Regions Hospital, and we also have the support of the St. Paul Area Chamber of Commerce. Thank you again for listening to our bed license request and for your consideration of this information. And I'm happy to answer any questions that you may have.
Thank you for your testimony. Senator Benson, do you have any comments, or should we go to questions?
Mr. Chair, let's go to member questions.
Okay, thank you. Any questions, members? I am not seeing any questions right now. Senator Benson?
Thank you, Mr. Chair. Oh, Senator Wickland, I'll defer.
Yep, Senator Wickland.
Sure. Thank you, Madam Chair or Mr. Chair and Senator Benson. I don't have any questions, but I just wanted to express that I signed on to the bill because I think there are unique qualities to this situation that we need to be involved in addressing this session. And I appreciate hearing the background information from Ms. Remark and understand how they got to this position. I'm glad to hear that all of the mental health, the behavioral health beds will be online this year. And I think that is really beneficial for the East Side system. Although, in general, just as a general comment about our mental health system, it's something that we should probably be taking a look at more generally as the Senate. Are we able to address mental health needs in the right way across our metro area and other parts of the state? And I think the answer is we don't have enough capacity, but I think that is something we need to be discussing as a separate matter, and how do we accomplish that? So just wanted to put forward my reasons for supporting it, and we'll be voting for the bill today.
Thank you, Senator Wickland. Senator Benson, any more comments?
Thank you, Mr. Chair. And just to note, you, Mr. Chair, are on this bill, as are Senator Pappas, Senator Wickland, and Senator Klein. And Senator Wickland and Senator Klein have done due diligence. I think in particular, Senator Wickland's had a number of follow-up meetings, and it makes me much more comfortable that we have looked at this from all points of view and determined as a legislature that there is a need that this bill will meet and help serve the needs of our community. So with that, Mr. Chair, I am grateful for my co-authors. I want to thank the partner care systems that are in the East Metro. Fairview and United have been very helpful in going through this process, and I appreciate them. So now I think it's time for us to move this bill and let regions run their hospital. With that, Mr. Chair, I would move that Senate File 953 be recommended to pass and placed on general orders.
Thank you, Senator Benson. Members, please turn on your cameras and be ready to vote here. All in favor of passing Senate File 953 and be referred to the floor, say aye. Aye.
Aye.
Aye.
Those opposed? Senate File 953 is on its way, Senator Benson.
Thank you, Mr. Chair.
I think you're up again here with Senate File 1156. And my understanding is you might have an amendment or so on that one.
Mr. Chair, to orient members, the A2 amendment was sent out, but the A3 should have been made available to you just recently. I'll be moving the A3 as an author's amendment. It simply aligns with the fiscal note and the timelines that we anticipate. It funds the fiscal note and then adjusts the timelines. And so, Mr. Chair, if I could move the A3 as an author's amendment.
I think first we have to adopt the bill. I didn't do that.
I'm sorry,
Senator Benson.
I didn't move. I will move Senate File 1156, and then, Mr. Chair, I'd like to move the A3 amendment.
Okay. Members, any discussion on the A3 amendment? I'm sorry, we need to vote on it first. So A3. So we are at Senate File 1156. The A3 amendment, members, you should have received an email probably 5 or 10 minutes before committee on that latest version. So all in favor of moving this author's amendment A3, please say aye.
Aye.
Aye. Aye.
Any opposed? Thank you. Senator Benson, to your amendment.
Okay, thank you, Mr. Chair. The federal government recently announced that they would be having an enhanced reimbursement rate for the COVID vaccine administration, moving us to Medicare rates, and that the feds would match it. And as this committee knows, you need to have some general fund money available in order to draw down that federal match. And why is this fiscal note so small? Because it only applies to our fee-for-service population. And so, Mr. Chair, if I could have Mr. Albrecht walk through the fiscal note and how it interacts with the appropriations article.
Okay, thank you. Mr. Albright?
Mr. Chair and Senator Benson and members, you can see on the first page that it shows general fund costs of $12,000 in fiscal year 2021 and $86,000 excuse me, in fiscal year 2022. Importantly, a couple of things about this fiscal note are that it is based on the November 2020 forecast, so it's good for about 2 more days, and needs to be revised after the February forecast comes out. I wouldn't expect it to change all that much, but it's important to understand that the November forecast on a high level assumed that both the governor's peacetime emergency and the federal public health emergency both end on June 30th of 2021. So that figures into this fiscal note in the sense that the enhanced rate or the higher rate applies while the federal public health emergency is in effect. And I believe that this Federal Secretary of Health and Human Services has actually communicated to the state that the federal public health emergency will be in effect at least until December 31st. But again, we prepare our fiscal notes relative to our forecasts. And so that new information that came out after the November forecast would be incorporated into the one I expect the February forecast. All of that to get to the point that Senator Benson made, which is, I believe it's on page 2 of the fiscal note, describes the interaction with the managed care plan and basically says that that the cost of vaccine administration is that the current capitation rates are sufficient to not require an additional appropriation, nor an increase in the capitated payments for the managed care portion of medical assistance. And then they go on to talk about, they assume that all of the vaccines that are administered by June 30th. And the reason that the appropriation is in fiscal year 22 is because there is a lag between the time a service is delivered and the time that it's paid for. And then at the bottom of page 2 and on the top of page 3 is a long explanation about the system's work. They need to program the system to pay the higher rate and then program it again when the public health emergency ends and it reverts back to the prior rate. And then after that are all of the tables showing which populations are included and how much is attributable to each population. Importantly, a big chunk of the population is the MA adults without kids. And remember that is matched at a 90% federal share, which really reduces the overall cost for this proposal. And then at the very end, at the bottom of page 4 is the table showing the amount of $12,000 for the system's cost in fiscal year 2021, and then $86,000 for the payments for vaccine administration in fiscal year 22. I would expect, Mr. Chair and Senator Benson, that when this is revised according to the February 14th. I wouldn't expect it to change all that much, though the exact timing might change a little bit. But I think if anything, it's going to say some people could show up in fiscal year 22, but they would be the same people. It's just that they would spread out longer the time that they might assume that they would show up and actually get their vaccine.
Thank you. Senator Benson?
Thank you, Mr. Chair. And I just want to clarify, if you look at the language on page 1.9, this section expires the last day of the calendar quarter in which the public health emergency for COVID-19 ends. This isn't dependent on our state public health emergency. This funding, this drawdown would be dependent on federal action. And so I just want that clear so that there's no confusion about the relationship between those two public health emergencies. If I could ask Mr. Chair, Matt Burdick from the Department of Human Services is here, and there's perhaps there's changes coming to this, and there's some reasons for moving this quickly, and I'm hoping the department can address some of those reasons. I believe Mr. Burdick was warned that I was going to be calling on him, but I don't know who else from the department might be able to speak.
Mr. Burdick,
thank
are
you,
available?
Madam Chair. Yes, thank you, Madam Chair. Matt Burdick with the Department of Human Services. I will give it my best shot, and if I stumble, colleagues will jump in and correct me. So as we understand it, the current federal legislation that is being considered related to COVID relief includes a provision that would allow for 100% federal matching funds for COVID vaccines. And so part of where there's a time sensitivity around this legislation is having our rate structure in place prior to that taking effect so that we're not perceived to be using that 100% federal matching fund to increase our rates in a way that wouldn't be appropriate. So we want to get this in place, but then the state's budget will benefit from that 100% federal matching fund that goes through the period of time that Senator Benson described in this bill.
Thank you. Senator Benson?
Mr. Chair?
Yes, go ahead.
Senator Benson, I didn't mention when going through the fiscal note, because the financing mechanism that is reflected in the A3 amendment deals with the cost attributable to this proposal by using prior general fund appropriations for COVID-19 and finding $98,000 worth of them that would be eligible to be paid by the Coronavirus Relief Fund, and directs the Commissioner of MMB to allocate $98,000 worth of expenditures, previous general fund expenditures, to the Coronavirus Relief Fund, appropriates that money from the Coronavirus Relief Fund, which makes the $98,000 available in the general fund. So a revised fiscal note would show no effect on the general fund. And I expect that is what will show up when this bill goes through the Finance Committee.
Thank you. Senator Benson.
Mr. Chair, I believe Mr. Burdick would like to comment.
Mr. Burdick.
Thank you, Mr. Chair. Just one correction to what I stated earlier. The federal legislation currently extends that 100% federal matching funds for 1 year after the expiration of the public health emergency. And so just wanted to make sure that timeline was clear for the record.
Thank you. Senator Benson.
Thank you, Mr. Chair. And I hope Ms. Kavanaugh made a note of that. Mr. Albrecht made a note of that. We might have an amendment for finance. I apologize. I wasn't up to speed on the 1 year beyond. And so if we need to extend it based on that 1 year, then I'm sure we'll craft language that will make sure we don't miss the opportunity. So with that, Mr. Chair, I have no further comments. We're doing our best to make sure that resources are available and to optimize federal drawdown of funds as we move through what I hope is getting to be the end of the pandemic and a return to a more normalized healthcare system, but making sure vaccine reimbursement is optimized is going to be critical.
Thank you, Senator Benson. Any other comments or questions, members? Senator Benson, anything else, or should we move Senate File 1156 as amended?
Mr. Chair, I move Senate File 1156 as amended be recommended to pass and sent to the Committee on Finance.
Thank you, Senator Benson. Members, please turn on your cameras. All those. Is that Senator Abler on audio there?
I'm just audio, Mr. Chair.
Okay, thank you. All those in favor of for Senate File 1156 as amended to be passed and as amended and referred to Finance, please say aye. Aye.
Aye.
All those opposed? Thank you, Senator Benson. 1156 passes.
Mr. Chair.
Yes. Senate File 1182.
Mr. Chair, Senate File 1182 has often been controversial. This is not the first time this proposal has been brought forward. We're working within the mandated reporter system. And you'll notice in the language of the bill, we had exempted mandated reporters from reporting on tetrahydrocannabinoid or alcohol usage, but everyone on this committee knows how damaging, in particular, alcohol can be to the fetus. And so it's odd that we exempt one chemical from reporting and then not others. So, Mr. Chair, I have the A1 amendment, which I hope helps reduce the controversy around this proposal. And I'd like to pass it as an author's amendment and then explain the bill in total. And so I would move the A1 amendment.
Senator Benson, did we do a motion to?
Mr. Chair, if we didn't, I will. I move Senate File 1182 be before us.
Thank you. And the intent of this is to pass it on and to go to civil law next, correct?
Yes, Mr. Chair.
Okay, thank you. So we have the A1 amendment, members. Do you want to describe the A1 a little more, or is it pretty straight?
I'll give a short description. So while if this language passes, would exempt these professionals, these healthcare professionals caring directly for moms and babies from reporting substance abuse. But I wanted to make sure that the woman does continue to receive appropriate care and participate in that care, because our goal is, healthy moms, healthy babies. And if she steps away from that care, then there need to be some consequences so that we have good cause to step back in. But as long as she's participating in the care, trying to get better, we need a path forward for that mom in this circumstance. And oftentimes pregnancy is the time when a woman will make a transition. And so getting her aligned with the care provider, she doesn't have to be afraid of being turned in for her abuse. She can be treated medically. Her baby can be respected as a patient, and they can both receive the care that they need. So with that, Mr. Chair, I want to make sure that the woman who does not continue to receive regular care, when the health professional attempts to contact the woman, then that professional would be required to report under the existing statute. And that is the A1 amendment.
Thank you, Senator Benson. Members, any questions to Senator Benson on the A1 amendment? Okay. All in favor of passing the A1 amendment, say aye. Aye.
Aye.
Aye.
Thank you. Any opposed? Senator Benson, to your bill as amended.
Thank you, Mr. Chair. And I believe there are a number of testifiers who've given notice to the committee. I'd appreciate it. They can tell these stories much better than I can.
Okay, thank you, Senator Benson. I believe up we have, and I apologize in advance if I mess up any names, but please state your name for the record and begin testimony. Dr. Stagley.
Yes. Hello, Mr. Chair and committee. My name is Dr. Elizabeth Slagle, and I am a practicing obstetrician and gynecologist in St. Paul, and I am the vice chair-elect of the Minnesota section of the American College of Obstetrician and Gynecologists. I represent nearly 1,000 providers of women's health care in Minnesota, and we strongly support Senate File 1182 and thank Senator Benson for highlighting this important issue. We can all agree that addiction and substance use disorders represent a public health emergency, a unique emergency in pregnancy. The question at the core of the discussion today is, does our law of mandatory reporting of substance use in pregnancy actually help our mothers and babies? I'm here to tell you that despite the best of intentions, the current law makes the problem worse. Pregnancy is a time when many women are very motivated to seek care, to improve their health, and address addiction. Criminalizing substance use disorders has been proven to be counterproductive. Our approach to substance use in pregnancy should be to support women and give them further motivation to seek prenatal care to improve their health and the health of their families. Mandatory reporting in pregnancy promotes a steady undercurrent of fear in our communities. And this fear erodes the trust between a woman and her provider and becomes a deterrent to prenatal care. I've taken care of many patients who have arrived at the hospital in labor without any care and are in crisis with their addiction. But I have also had countless patients that have been lost to prenatal care when concerns around substance use are surfaced during their pregnancy. One patient who had been engaged in treatment for opioid addiction unexpectedly became pregnant and became lost to care. She experienced heavy bleeding at 30 weeks of pregnancy and delivered a preterm, low birth weight infant who spent months in a neonatal intensive care unit. The patient stated that she stopped accessing care and treatment once she got pregnant, fearing that she would be penalized for her addiction and have her child taken from her. In obstetrics, we are fighting a serious rise in maternal mortality, in enormous health inequities, and rising rates of substance use. In the US, it is more dangerous to give birth now than it was a generation ago, and it's far more dangerous for women of color. So we need to make sure that every law and policy as it relates to pregnancy care has the actual intended impact to improve access to care, to improve trust between the patients and their providers and the communities that serve them. States without mandatory reporting in pregnancy have avenues to report concerns over the safety of pregnant patients. By removing the mandate to report, reporting can still exist in scenarios that are necessary. As physicians, we are heavily involved in working with social services to intervene when life and safety of a patient or a newborn is at stake. For example, if I have a patient with a severe catatonic depression, for example, a rare form of depression where the patient may not be interactive or able to communicate, then I can still report this to the state and social services to investigate the core question of whether the person at this particular moment in time is capable of parenting. If a pregnant woman is known to suffer from substance use disorder and does not receive care, that is reportable. I have taken an oath to treat my patients with dignity and respect, and to always strive to establish a therapeutic alliance with my patients. I also believe in the ethical responsibility to discourage the separation of parents and their children solely based on substance use disorders. I implore you all today to align the law to this oath and responsibility by supporting Senate File 1182. Thank you.
Thank you for your testimony. Next, we have Dr. Alabi. Once again, please state your correct name for the record and begin your testimony.
Mr. Chair, members of the committee, my name is Dr. Elizabeth Alabi, and I am a practicing obstetrician gynecologist at Hennepin Healthcare. I've been here for 4.5 years, and my sites include our Brooklyn Park location, our downtown campus, as well as the Hennepin County Jail. I'm currently delivering babies today, so I'll try to make my testimony short, as I might be called away unexpectedly. At Hennepin Healthcare, roughly 80% of our patients within our system are on Medicaid, and a majority of those pregnant, postpartum, and birthing moms are of Black, Indigenous, and people of color. Maternal health providers see firsthand the stressors that moms experience while pregnant in their first year after birth. Pregnancy is also a time that many women are presenting to care, and it's also a time that they are willing to make pretty substantive changes in their lives. I meet mothers all the time who are trying to do the right thing by getting treatment for their substance abuse as well as mental health disorders while pregnant. We work with a demographic of patients who already have a pretty strong distrust of the medical system, and we spend the entire pregnancy trying to earn that trust while getting them the full breadth and benefit of prenatal care. That care, however, is undermined.
Attention hospital personnel will be doing a test of the fire system.
Mr. Chair, that,
yeah, sorry.
That might be a first.
Sorry about that.
No.
But that trust is undermined by reporting moms who have been getting regular prenatal care, treatment for their substance abuse, when we report them to CPS. The fear of having their child taken away is now a barrier and a determinant to care. We know that prenatal care, education, and supportive programs are one of the biggest determinants of improving outcomes in both the mother and child. I recently attended a birth with a mom with a history of substance abuse. We called in the neonatal intensive care team, the NICU, as she was nearing delivery, not because of her history, but because the baby had a bowel movement during labor. And as the NICU team entered the room, she began to cry out while pushing, "Please don't take my baby. Please don't take my baby." And the fear that she felt from CPS just kind of swooping in and taking her baby, who wasn't even delivered yet, was palpable throughout the room. She shut down after this, as did her interaction with the rest of the care team. We know that CPS involvement is disproportionate when it comes to our Black, Indigenous, and people of color. And we also know that dividing families does not necessarily improve outcomes. So thank you for allowing me the opportunity to share this story. This bill will truly mean more moms, babies, and families staying together, which will allow us to focus more on the prevention, treatment, and support that they really need.
Thank you. And members, do we have any questions for either doctor before they go on and save babies and moms? Thank you for your work on it. Members, if not, we'll go on to our third testifier. I want to see Miss Zilverstand. I hope I got that right. Please correct me and state your name for the record and begin your testimony.
Mr. Chair, I believe she's also a doctor.
Okay, I'm sorry.
That's all right.
Mr. Chair, members of the committee, my name is Anna Zilverstand and I'm an assistant professor of psychiatry at the University of Minnesota, working with the medical discovery team on addiction. I represent a team of researchers at the U of M that has an opportunity to participate in a landmark brain and child development study funded by the National Institute of Health. This study plans to enroll 10,000 pregnant women across 25 study sites in the United States starting this fall to study the effects of neonatal abstinence syndrome, a medical condition in which babies experience drug withdrawal symptoms at birth. Unfortunately, in the past 15 years, the incidence of neonatal abstinence syndrome has increased 5-fold nationally and 9-fold in Minnesota. While preparing this study, I've talked to several lawyers about mandated prenatal reporting in Minnesota, and after months of preparations, it is still unclear if and how we will be able to conduct a study without legal risks for the participating women. Minnesota is the only state among the 25 study sites that are participating which has mandated reporting of substance use during pregnancy by researchers or educators, making it nearly impossible for us to conduct our research without adding legal risks for these women, even though we are providing healthcare services to the women who are participating. This bill would change this, and I'm absolutely convinced that passing it would improve the future welfare of the mothers and the unborn babies, both in the short term, but also in the long term, through the scientific insights that we will gain. This is also important because without us participating, there won't be any data specifically on Minnesotans. And I want to stress this, we will invite families from all across the state to participate. Finally, we've actually been flagged on a national level by the National Institute of Health as being the state with the most punitive legal situation among the current grant applicants. This now not only risks our application to be a study site, but also risks the chance for the U of M to be the data center for the entire study unless this law is changed. I thank you for allowing me to testify, and I'm available for questions. Thank you for Representative Morrison for authoring this legislation.
Thank you, Doctor. Any questions for our three testifiers, members? Senator Benson.
Thank you, Mr. Chair. I think we've reached a time when, addiction has to be treated as a medical condition. And if the individual fully participates in their path towards recovery, we have much better outcomes. And so let's not put a barrier to moms getting the treatment they need to help the babies that they're carrying at this really critical point in the life of their family and their child. And so I see Senator Wickland's hand is up. I'll let her finish.
Okay, thank you, Senator Wickland.
Thank you, Mr. Chair. I just wanted to add my support and say I really appreciate that this bill is moving forward, and the testimony is really compelling that it will have a positive impact on many women's lives and their children, and look forward to seeing more ways we can emphasize prevention, education, and support of mothers. So thanks for bringing it forward.
Thank you, Senator Wickland. Senator Benson. Oh, I see another hand. Senator Eaton.
I'm sorry. I just had to add my support. I'm so grateful that you brought this bill forward, Senator Benson. It's very important and I appreciate it.
Thank you, Senator Eaton. Senator Benson.
Mr. Chair, in COVID legislating, I signed the jackets and dropped them. So anybody who'd like to hop on as a co-author, let Jonathan know. We'll make sure that happens. I'd like to leave one space for the civil law chair just to make my life easier there, but everybody's welcome to join. And with that, Senator Wickland said it well. And so I will move, Mr. Chair, that Senate File 1182 as amended be recommended to pass and referred to the Committee on Civil Law.
Thank you, Senator Benson. The members, please turn on your cameras. All those in favor of passing Senate File 1182 as amended, say aye.
Aye.
Aye. Aye.
Any opposed? Senate File 1182 passes. Senator Benson, back to you.
Thank you, Mr. Chair. That's all I have today. I think when you chair, we get through our agenda very quickly. So committee might appreciate that a little more frequently. Mr. Chair, if you would like to wrap up committee today, we'll have our regular meeting time next week. Just for members' awareness, I did receive an LAC request regarding some federal funds that we have already discussed in committee. I'm doing a little more digging in. The Department of Health has had a mix of responsiveness, but we're gonna look through the federal funds request. I'm gonna try to keep Senator Wickland up to date so that there's no surprises and I get some pushback from the other caucus if necessary. Finally, I still haven't received the Vault Health contract, and that's come up a number of times. And I don't know when I'm going to receive it, but for members' awareness, I did make a request and that has not been received yet. So we'll keep pushing. Thank you, Mr. Chair.
Thank you, Senator Benson. Members, with that, we are adjourned for the day. Thank you.
Thank you.